an email in the chat. That helps us with our attendance records and for follow-up resources. We're going to go ahead and get started just so we don't run out of time today. Like I said, in the chat, if you could provide that information, we will follow up with some additional resources at the end of the session. And we'll go ahead and start with some introductions here. I am Krista Opsdahl. I'm the ECHO Project Director at the North Dakota Center for Persons with Disabilities at Minot State. Kyle, do you want to introduce yourself?
I'm Kyle Erickson. I'm a research associate here at Minot State.
Kyle and Jody.
Hi, I'm Jody Patchen, and I am the administrative assistant for Project ECHO at Minot State.
We also have with us Nancy Hostetter. Oh, you're muted.
Oh. Okay, sorry about that. Hi, I'm Nancy Hostetter, and I work with the UND School of Medicine and Health Sciences with the CME. Thanks.
Thank you. We also have Amy Burke, who's not feeling too good today. So she's with the newborn screening program at the Department of Health in North Dakota, and Joelle Meyer.
Hi, everyone. Joelle Meyer with the newborn screening program, and I am at the Department of Health and Human Services. So welcome for our last ECHO session.
Joelle, do you want to introduce our presenter for today?
Yes, I would love to. We are very happy to have Amy Gaviglio here with us again, and she is a certified genetic counselor and founder of Connetics Consulting, which provides public health genetics, genomics, and rare disease services across the country. And she's been working on newborn screening and rare disease, or working in the newborn screening and rare disease space for 15 years. Amy currently works with the Center for Disease Control and Prevention's Newborn Screening and Molecular Biology Branch, the Association of Public Health Laboratories, Expecting Health, and several other genetics and rare disease organizations. She is the co-chair of APHL's New Disorders in Newborn Screening Workgroup and is a member of the additional national groups, including the Legal and Legislative Issues on Newborn Screening, Rare Disease Diversity Coalition, EveryLife Foundation's Community Congress, and she also serves as the advisor for the Midwest Genetics Network and Innovations in Newborn Screening Interoperability Center. Finally, Amy serves as the chair of the Newborn Screening Expert Panel for the Clinical and Laboratory Standards Institute and is currently serving as the chair for the Minnesota Rare Disease and Advisory Council. And I've worked with Amy for, gosh, I think 8 years, and she does all of that and more, trust me. So we're very excited and happy to have Amy do our learning presentation here this morning. So go ahead, Amy.
All right, thank you so much, Joelle. Can you hear me okay?
Yes.
Excellent. So thank you for inviting me back and for allowing me to talk about a topic that is really, really near and dear to my heart, and one that I've been really trying to spend more time on in the last few years, which is the idea of health equity and providing culturally effective care. So next slide, please. So I want to start us out today, and you can kind of go to the next slide as well, but essentially by level setting us on some terminology. And while I think these terms are being used more and more, but rarely in my experience are they ever, or have they ever been really explicitly defined. And I really am a strong believer that ambiguity in definitions can lead to delays or confusion in action. And so I just like to start with some terminology just to kind of baseline us. So we'll start with the term health disparity. And health disparities are preventable differences in the burden of disease and our opportunities to achieve one's ideal health, and are often linked to social, economic, or environmental disadvantages. So, of course, not all health differences that we see in healthcare are health disparities. So, for example, a higher rate of concussions seen in NFL football players would not be considered a health disparity per se, because the difference is not really connected to the kind of underlying and overarching concern of health disparities, which is essentially social justice. So you may also, we often hear the term health inequity as well. And this is essentially another way to say a health disparity. So again, here we are really focused on those differences in health outcomes that are and can be traced to unequal economic or social conditions that are systemic, avoidable, and unfair. Next slide. So then what do we mean when we use the term health equity? Again, in its broadest and simplest form, health equity means social justice in health. It means that no one is denied the possibility to be healthy simply because they belong to a group that has historically been or is currently being economically or socially disadvantaged. And of course, this concept of health disparities and health equity are obviously very closely linked, because health disparities are essentially a metric by which we can measure our progress or lack thereof towards health equity. Next slide, please. So another kind of level set for us is I often see the terms equality and equity being used kind of either interchangeably or maybe in the wrong context. And rather than kind of using the same image that I think so many people use in this space with the kids standing on different levels of boxes that showed the difference between equality and equity, I really prefer this quote from Carolyn Belden that states that equality is leaving the door open for anyone who has the means to approach it, but equity is ensuring that there is a pathway to that door for those who need it. And what this means, I think, is really that providing the exact same door, the exact same opportunity, screening tests, diagnostic tests, treatment to each individual does not ensure that the unique needs of that individual are being met, or that you have really set them on the path to optimal health outcomes. Next slide. So lastly, as it pertains to terminology, at least in this space, I want us to really be clear about the terms availability, accessibility, and equity, and most importantly, how one does not necessarily lead to the others. So when we talk about availability, we are really talking about just simply the existence of healthcare resources, such as things like screening services, diagnostic services, treatments, enrollment in clinical trials or research options, as well as education and advocacy. But availability is not the same as accessibility, or the ability for someone to actually reach or utilize those services. Likewise, availability and accessibility do not necessarily in and of themselves result in equity, or the idea that everyone has that chance through these services to attain their highest level of health. So next slide. So all of this really plays into the healthcare maze, and I think the maze metaphor is really appropriate when we're talking about our healthcare system, and especially when we are thinking about providing families with things like timely and accurate diagnoses. I really like this image because I think it shows fairly clearly how all of these different things, whether it's systemic racism, geography, insurance, one's health literacy or education level, miscommunication can really throw some pretty significant wrenches into what is already a very difficult system to navigate. And so you can easily see where disparities may start to arise as a result of these issues. Next slide. So with that, let's kind of shift to the concept of providing culturally competent care as one way to begin to both acknowledge and address health disparities. So next slide, please. So first, culture can mean really a number of different things above and beyond where I think our minds usually go, which is often kind of the concepts of race and ethnicity. And truly, though, culture often represents the intersection of many of these things that are shown on this slide. So when we are talking about providing culturally competent care, we really should be thinking about all of these components in doing so, and how they may intersect with various individuals to lead to kind of their feeling of cultural identity. Next slide, please. So again, I'm sorry, I'm the daughter of an English teacher, so definitions and terminology is really important to me. So I want to just take, again, some quick time for some definitions, this time focusing on the concept of cultural competence and cultural humility. So cultural competence is a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among individuals that really enable that system, agency, or those individuals to work effectively in cross-cultural situations. So what I want to highlight here is that cultural competence is not just something to be achieved at the individual level, but is truly something that needs to be addressed and implemented at the organizational level. And in a few slides, we'll talk a little bit about what implementation may look like at both levels. So cultural competence then differs from the concept of cultural humility, which is, again, this ability to maintain an interpersonal stance that is other-oriented or really open to others and open to their differences. It's really different from other culturally based ideals or things like cultural competence because it focuses on kind of that self-humility rather than achieving a state of knowledge or awareness, particularly as it pertains to a culture to which you don't belong. So in essence, cultural competence can be seen more, I think, as the kind of structural and knowledge-based part of thinking about culturally effective care, whereas cultural humility can be seen more as kind of that internal belief or internally focused system or state. Next slide, please. So not surprisingly, both of these are really important when we think about providing culturally effective care. So again, cultural competence is really a bit about that knowledge. What are their cultures like? What do they believe in? What strengths do they have? And really then thinking about how it interacts with your own culture and your own self-awareness of your culture. How does your culture influence the way that you view and interact with others? Cultural humility, again, is more in this kind of understanding, but also beginning to think a little bit more about addressing some of, areas of systemic oppression. How can you use your understanding of your culture, your understanding of other cultures that you've gained through cultural competent work to really try to address health equity and make a difference in this space. Next slide, please. So again, I want to kind of drive home how this concept of health disparities and working towards health equity, really how important this concept of culturally competent care is in this. I think sometimes it's thought not considered as a potential kind of next step for addressing this, but it is really, really important. So this shows how health disparities are driven by a number of issues or social determinants of health, whether it's economics, geography, education level, food security, ability to communicate, but also really focusing on the healthcare system in the green box. And you can see how this access to linguistically and culturally appropriate and respectful care can really, really impact health and well-being, and can be a really nice first step. And maybe even kind of a lower hanging fruit first step of trying to address, acknowledge, and deal with health disparities. Next slide, please. So I really like this figure. It's from a fairly recent article by Hankey et al., where they really did this nice scoping review of different strategies for implementation in healthcare organizations. And what I like about this is that it reiterates that concept that culturally effective, culturally competent healthcare really needs to be both at an individual and organizational level. So in the interest of time, I won't go through all of these, but I will highlight a few things. So one I want to highlight is this idea of just even doing a needs assessment of your organization, of yourself in where you are as you're thinking about providing culturally competent healthcare. It's really hard to start addressing things if you haven't first assessed where you are at and how things are going. And I'll show a few options for self-assessments and organizational assessments later on. Of course, just doing an assessment in and of itself is not enough. Once you identify the gaps and needs, really developing those action plans is really, really important. And so the action plans can include things like providing culturally competent training or competence training for healthcare providers. And I would say not just for healthcare providers, but for anyone who is dealing or touching a family that comes into clinic, whether it's administrative staff, nursing, MAs, physicians, really across the board. Thinking a lot about the integration of both interpreter services and translation services. Thinking about your physical and social environment. What is it like when a patient walks through that door, and how does it relate to where they're coming at their sense of identity? From the individual level, again, just participating in those trainings, thinking about what you need to do, thinking about where you're at, and again, kind of thinking about those self-assessments as well. So next slide, please. So this is another kind of way of looking at some of what was presented on that last slide. And I just tried to kind of piece it out so that it was a nice, easy, clear action plan of steps that one can take to start to provide culturally competent or culturally effective care. So the first is, of course, just valuing diversity, understanding that kind of being in an echo chamber is really not helpful for anything. And so starting to change that mindset of considering differences as really strengths. And we talked already a bit about this cultural self-assessment and organizational assessment. I'll get to that again later. Being more conscious of the dynamics that happen when people from different cultures interact, and appreciating what works well in those situations and what can be improved. Institutionalizing cultural knowledge. So this again gets back to really needing this to come from and be systemic within the organization, that this cultural idea of cultural competency, cultural humility is ingrained at all levels of the organization. And then, of course, adapting service delivery as needed to reflect that understanding and appreciation of cultural diversity. And again, adapting it in a way that's not necessarily providing the same thing to everyone, but providing what each individual actually needs for success and for health. Next slide, please. So I just put a few links here in terms of tools that are already available that you can easily go to and print them off, or you can take them electronically on cultural competency. So the American Speech Language Hearing Association has some really great ones. They're not necessarily just geared towards individuals with hearing loss or individuals with speech impediments, but really just overarching. And so you can see they break it down both into service delivery, which I would see more as that organizational level, as well as personal reflection, which is more really looking internally at you. There's another one, the one on the right is from the American Academy of Family Practitioners. This is another really great self-assessment that's obviously focused more to primary care and promoting those cultural and linguistic competencies. Highly recommend just taking them and just kind of level setting yourself. It's really eye-opening sometimes when you actually take the time to self-reflect on where things are at. Next slide. So I hope that provides a nice baseline and guide for starting this. It's impossible to really cover the concepts of health equity and culturally competent care in such a short time, but I hope that at least this sparks the discussion and leads nicely into Melody's case for the day. So thank you.
Thank you so much, Amy, for that presentation. We are going to